all to today's session. Myself Rajita, and today we are going to deal about a very interesting topic of medical surgical nursing. We are going to deal about shock today. Now, it is basically a syndrome which often causes multiple organ dysfunction. So, here we are going to learn about in details of shock, the definition of it, the probable causes, the pathophysiological changes, clinical manifestations associated with it, as well as the management of it. So, let's get started with the shock. So, shock is basically a physiological event that have different causes, but ultimately it is going to lead to development of one single particular dysfunction, that is multiple organ dysfunction for a particular individual. So basically what happens in this disorder named as shock? Here basically we are going to see, because of many etiological factors, ultimately there will be inadequate delivery of the oxygen and nutrients to the cells of the body, and there, as the cellular demand is not met, that is the reason an individual will be developing with various clinical manifestations. So in this kind of dysfunction of shock, we are going to see there will be development of profound and widespread reduction of the effective tissue perfusion. Initially, it will be causing a reversible dysfunction, but if this profound and widespread reduction of the effective tissue perfusion is prolonged for a long time, we are going to see the individual will be developing with irreversible dysfunction in their body. So no matter whatever the causes and etiological factors are in this shock, ultimately we are going to see it is bringing one particular change in the individual's body, which is ultimately developing the manifestations related to shock. Now, the changes which all the etiological factor is bringing is definitely a imbalance of oxygen and nutrients supply and demand. So now we are going to learn about the definition of shock. So shock is basically a life-threatening situation. It almost always caused by the poor tissue perfusion and impaired cellular metabolism, ultimately which is going to develop serious and severe clinical manifestations and pathophysiological dysfunction. Shock is basically also termed as a clinical syndrome, where we are going to see that it will be developed with when there is impairment of the tissue perfusion throughout the body. Now, shock can be almost always associated with a circulatory failure due to the underlying disease process or underlying etiological factors. So, in this clinical syndrome of shock, we are going to see basically here one particular change is permanent, that is a cardiovascular collapse. Due to the cardiovascular collapse, we are often going to see two phenomena in this clinical syndrome of shock. The two phenomena are an effective reduction into the circulating blood, which we often call or term as hypotensions, right? So definitely here the reduction of the blood circulation will be there. Now, due to the reduction of the blood circulation, we are going to see the second phenomena associated with shock, that is inadequate tissue perfusion, which we often term it as hypoperfusion. So hypotension and hypoperfusion, these are two common manifestations or initial manifestations almost always associated with shock. Now, as we have seen that there will be circulatory collapse as well as inadequate tissue perfusion. Now, initially, you have to remember our body will try to compensate this particular condition. But as if the compensatory mechanism fails for a particular individual, we are going to see the development of severe clinical manifestations and multi-organ dysfunctions in this clinical syndrome. Inadequate tissue perfusion and cellular dysfunction often will be related to the damage associated with the molecular patterns and the inflammatory mediators. We are going to also see the presence of maldistributions of the blood flow, which will be compromising all the functional abilities of the body organ, even the vital organs. Next, definitely we are going to see the process will be, progressed further, and if it is uncompensated, we are going to see the development of shock for individual. So as we have understood the basic concept of shock, we have seen the basic two phenomena which are very commonly associated with it. Now we shall learn about the classification of this clinical syndrome of shock. Now, the general classification of shock basically categorize two type of shock, or it categorizes the shock into two types. Those are first the primary or initial shock, and the next one is the secondary, or what we call it as true shock. So first here we're going to learn about the primary or initial shock. So basically the primary or initial shock is a transient change which is basically caused by a vasovagal effect. Now, due to a sudden reduction of the venous return, this primary shock can actually develop for an individual body. Now, other causes associated with the development of initial or primary shock is neurogenic vasodilatation, as well as some consequent peripheral blood pooling often will be associated with the development of primary and initial shock. Now, the secondary or true shock, here we are going to see it will be often associated with certain underlying severely progressed disorders or disease. For example, heat stroke, a severe traumatic injury which is causing a severe hemorrhage for a particular individual often will associated with the development of secondary or true shock. Now, heart attack, even the poisoning, even some disorders and diseases like neurological associated or neurology associated disorders also will be associated with the development of secondary and true shock. So I hope you now clear about the basic classification of shock that is categorized this clinical syndrome into two. One is the primary and initial shock, and the second one is secondary or true shock. Now we are going to read about the next classification of this clinical syndrome of shock. Now, this classification is basically depending on the etiological factor which is causing the development of this syndrome. So, depending on the etiological factor, we are going to classify the shock into hypovolemic shock. Now here first we're going to learn about what do you mean by hypovolemic shock. So as the term hypovolemia is suggesting that there is volume insufficiency or deficiency of the volume. Now definitely it is indicating that in hypovolemic shock, often an individual will be having deficiency in their blood volume, even the fluid volume for their body. So it is basically an emergency condition where we are going to see there is loss of fluid and blood due to certain etiological factors, which is ultimately causing a severe loss of fluid and blood from the circulation. That is the reason here in hypovolemic shock, we are going to see often that the heart here will not be able to pump adequate amount of blood for maintenance of adequate tissue perfusion. That is the reason in hypovolemic shock, the client will be developing with certain clinical manifestations, and it is definitely considered as a very emergent condition. Now, what are the causes of hypovolemic shock? Basically, we're going to see the causes are hemorrhage or bleeding. Now, this hemorrhage can be internal or external. Now, basically, bleeding for cuts, even bleeding from injuries, that can be a traumatic injury if it is severe enough to lose severe amount of blood and fluid, definitely it is gonna cause or development of hypovolemic shock for the particular individual. So in internal bleeding, like for example, if a person has have attend to a traumatic injury which has caused an internal bleeding inside the brain tissues, we are going to see here the internal bleeding is basically caused for a traumatic injury patient. Now here what is happening, the blood and fluid is escaping from the vessels and circulation and is getting accumulated into the tissue spaces. Here, in this type of injuries or internal bleeding cases, we are going to see the tissue spaces will be accumulated with blood, but there will be insufficiency of the circulated blood and fluid into the blood vessels. That is the reason we are going to see internal bleeding will often develop the condition of hypovolemic shock. The next condition, which is almost always associated with the development of hypovolemic shock, is burn. Now, burn injury often cause extensive fluid loss. That is the reason almost always in a patient with burn, they are having very high risk for the development of hypovolemic shock. Excessive diarrhea often will be associated with hypovolemic shock. Now, if an individual is having the symptoms of diarrhea and if it is not managed into an initial period, and if the person is having an extensive level of diarrhea, we are definitely going to see in a progressed state the excessive diarrhea can ultimately will be causing a huge amount of loss of fluid from the individual's body, that ultimately will be leading to the development of hypovolemic shock. Excessive vomiting also will be associated with the development of hypovolemic shock. As we know, through vomiting, a person, if they're having excessive vomiting, they will be actually losing a huge amount of fluid. And that is the reason a person actually can develop hypovolemic shock. A person with an extensive or a excessive amount of perspiration, basically in a state where the person is having diaphoresis, we're going to see if it is not managed in an initial period, the person actually can develop hypovolemic shock in extensive way. So here the hypovolemic shock actually can be classified into two. So basically, we're going to see the two classification includes the absolute hypovolemic shock, and the second one is a relative hypovolemic shock. So first, we're going to learn what do you mean by a absolute hypovolemic shock here. So absolute hypovolemic shock will be including all the conditions which is basically composed or consist of external loss of whole blood, which is basically occurring if our client is having a severe hemorrhage. So for example, if a person has got a cut or a severe wound or traumatic injury on the body surface, and if they're having a severe hemorrhage, we're going to see the external bleeding is definitely helping the client to lose huge amount of blood. Losing whole blood will be causing a absolute hypovolemic shock. Next, we are going to learn about relative hypovolemic shock. Here, basically, not exactly the whole blood will be lost from the circulation. So here, we are going to see the pooling of the blood will be basically occurring from the circulatory blood vessels into the tissue spaces. So relative hypovolemia often will be associated with the conditions like burns, or maybe the cases like bowel obstructions and so on. Here, basically, we're going to see that the pulling of the blood and fluid from the vasculature will be ultimately causing the heart inability to pump adequate amount of blood for throughout the body in order to maintain or manage the tissue perfusion. That is the reason here the pulling of the blood and fluid into the tissue spaces will be ultimately causing hypovolemic shock, as it is ultimately decreasing the volume sufficiency inside the vasculature. Next, we are going to learn about the second classification of shock depending on the etiology. This one is termed as cardiogenic shock. So, as the term here itself is suggesting, the cardiogenic shock, it will be almost always associated with the dysfunction or inability or loss of functional ability of the heart. Now, as the heart here is losing its functional ability, definitely we are going to see the pumping action of the heart here will be decreased. Due to that, the circulation of the blood will be improper, and ultimately the demand of the oxygen and nutrients by the body cells will not be managed by this dysfunctional heart. So this cardiogenic shock, often considered to be an emergency conditions or emergency treatment, it's needed to manage the cardiogenic shock. Basically, here, as I have mentioned, the heart will be unable to pump the blood to meet the adequate oxygen and nutrients demand from the body cells. That is the reason we are going to see poor tissue perfusion will be almost always present associated with the cardiogenic shock. Now, we're going to read about the major and most important and common causes of development of cardiogenic shock. Now, preferably, almost all the cardiovascular disease ultimately can lead to the development of cardiogenic shock. The most common disorders or disease of heart, which are almost always leads to the development of cardiogenic shock, includes myocarditis as well or as endocarditis. Basically, it is suggesting the inflammation of the myocardium or muscle layers of the heart, as well as the endocardium layer or the innermost layer of the heart. So inflammation of endocardium and myocardium, as we have studied in cardiovascular disorders, that it is often will be associated with the dysfunctional or impaired ability of the heart pumping action. Now, this process or this disease condition ultimately can develop cardiogenic shock in a progressed state. Pericardial tamponade often will be associated with the development of cardiogenic shock. What basically happens in cardiogenic shock? In any disability or any pathophysiological process which is affecting the myocardium layer of the heart will ultimately decrease or decreasing the functional ability of it. There's a reason here the heart will be losing its contractile ability, so we are going to see the blood circulation will be decreased into the peripheral areas. That is the reason the client can develop with the symptoms associated with cardiogenic shock. Now, heart failure and heart blockage almost always will be associated with the development of cardiogenic shock if these conditions are not managed initially with medical management or a proper surgical management. Next type of classification of shock depend on the etiological factor, basically classified or named as distributive shock. Now, in distributive shock, we are going to see three major classification. Now, it includes first about the septic shock. So first here we're going to learn about the septic shock. So as the terminology is suggesting, septic, it is almost always associated with sepsis or a severely extended infection for a particular individual's body. So this shock can be related with if a person is developed with wide infections in their body, which is ultimately affecting the functional ability of the heart as well as the circulation of the blood throughout their body. So septic shock is basically considered to be one of the most common complication associated with sepsis or a severely progressed infection state in an individual. So we're going to see the septic shock often will be manifested associated with a very decreased or low level of blood pressure. This basically suggesting that the blood or the heart is not able to pump adequate amount of blood to the circulation so that adequate amount of circulation or perfusion can take place for the body tissues. Next, we are going to see often there will be presence of altered mental state. As almost always in septic shock, we are going to see the cerebrovascular perfusion is disturbed here. The next feature associated with septic shock is a multi-organ dysfunction syndrome. So basically in multi-organ dysfunction syndrome, we are going to see the extended, widespread infection will be ultimately affecting all the vital organs inside an individual's body, and ultimately it will be causing dysfunctions of all these vital organs, and that syndrome is termed as multiple organ dysfunction syndrome associated with septic shock. Now, septic shock will be often result as a systematic response towards an infection or multiple infections that are present in individual body. Now here we are going to read about certain infections which are often will be associated with the development of septic shock. Now this precipitating factors which we are going to learn now, if it is severe enough, can definitely lead to the development of septic shock. So the examples are appendicitis. So if a client is diagnosed with appendicitis and if initial management or surgical management is not administered, appendicitis actually can lead to the development of septic shock for the particular client. Pneumonia, bacteremia, and diverticulitis are almost always associated with the development of septic shock. Meningitis, pancreatitis is very commonly associated with the development of this type of shock. Multi-drug resistant infections or infectious organisms associated disorders and mesenteric ischemia. These are very common type of conditions which often will be related to the development of septic shock. Now, you have to remember the septic shock actually can occur if the infection is not treated at initial period, or if the infection has gone into a very progressed state where it is not able to manage. Majority of the cases we are going to see if the multi-drug resistant organisms are present associated with the development of infection for individual, we are going to see they will be having a high chance or high risk for the development of septic shock. Now next we are going to read about the fourth classification of shock depending on the etiological factor, and it is also a type of distributive shock like septic shock. So this distributive shock is also termed as neurogenic shock. So basically the neurogenic shock almost always will be associated with the development of extensive vasodilatation in an individual's body. Here, dilatation of the vasculature is occurring inside the client's body due to an imbalance into the neurological function. So as we have learned, the neurology or the neurons or basically the nervous system have two basic classification. The first one is parasympathetic and the next one is sympathetic nervous system. What happens here due to the imbalance of the functional ability of parasympathetic nervous system and sympathetic nervous system almost always will be fail to maintain the diameter of the vasculature inside the individual. There is a reason here in this type of shock we're going to see the client will be having an extensive vasodilatation. Ultimately, as it is increasing the vascular capacity, we're going to see there will not be presence of any adequate tissue perfusion or adequate blood circulation. Vasodilation is ultimately will be leading to the development of a condition where the heart will not be able to pump enough blood to match the need of the tissue perfusions. So that is the reason here we are going to see the neurogenic shock often can occur if there is an imbalance between the parasympathetic and sympathetic nervous system's activity. Now the next one is anaphylactic shock. Basically, the anaphylactic shock is considered to be a severe, potentially life-threatening allergic infection. So next we are going to learn about the third distributive shock and the fifth classification of the shock depending on the etiological factor, that is anaphylactic shock. It is considered to be one of the major horrible life-threatening scenario that can happen to a person. So allergic or anaphylactic shock is a very severe life-threatening scenario developed as an allergic reaction. Now this anaphylactic shock actually can occur within a seconds from minutes for an individual body if the individual is exposed to external stimuli which or towards which they are allergic to. The examples are peanuts or bee stings, this all or certain chemicals which often will be causing allergic reactions to some people. Now, some people will be having extensive allergy towards dusts or maybe certain particular chemical materials. Now, suppose if an individual who is very severely allergic towards the dust often can actually get for the allergic reaction development once they are exposed to the particular stimuli towards which they're allergic to. Now, anaphylactic shock occurs if the allergic reaction is very severe enough or if the body's response has been very severe towards the allergic response. So basically in anaphylactic shock, we're going to see our immune system or individual's immune system will be causing a flood of chemicals once they're exposed to the particular allergic stimuli. It will be definitely going to cause a complete dysfunction of various vital organs inside the body. Ultimately, that can lead to the development of shock. Here in anaphylactic shock, the basic symptoms includes there will be a complete reduction of the blood pressure. So definitely we're going to see here in anaphylactic shock, a client almost always will be present with a hypotension due to the inability of the heart to pump adequate blood for the circulation and to maintain the tissue perfusion. Next one is definitely the airway will be compromised in anaphylactic shock. Often we are going to see the client will be hypoventilated or hyperventilated in case of anaphylactic shock. Also, there will be complete blockage of breathing can take place if there is a severe inflammatory reaction is present associated with anaphylactic shock, which often can lead to the development of a life-threatening scenario, because you have to remember the anaphylactic shock actually can develop within a seconds even. Now, the next type of classification of shock we're going to read about, that is named an extracardiac obstructive shock. Now, extracardiac obstructive shock, depending on the pathophysiology of this type of shock, actually can be dividing its cause into two categories. The first one, which is almost always will be associated with the development of extracardiac obstructive shock, is a hugely or severely increased intrathoracic pressure. Now, severely increased intrathoracic pressure almost always will be associated with the development of extracardiac obstructive shock. The next common feature associated with this obstructive shock is intrinsic vascular flow obstruction. Here we are going to see the cardiac or actually the heart will be able to pump the blood or adequate blood, but there is presence of certain obstruction into the vasculature which will be disrupting the blood flow for the managing the tissue perfusion. So this two mechanism is basically cause the development of extracardiac obstructive shock. Now the primary effect of both this type of categories actually can be either a pump failure of the heart or maybe a loss of preload. Now, if there is pumping inability of the heart, we're gonna see that the pump failure basically occurs if the cardiac output is compromised. Whereas the loss of preload can occur if there is inadequate venous return or inadequate return of the blood from the peripheral vasculature. Now, this often will be leading to the development of adequate or inadequate tissue perfusion and lead to the development of obstructive shock. Physical obstructions which will be often associated with the development of this kind of shock includes the presence of cardiac tamponade, the tension pneumothorax, which is basically increasing the intrathoracic pressure for the individual, as well as superior vena cava syndrome. Now, this often will be associated with the inability of the heart to pump blood, as well as basically the superior vena cava syndrome will be often causing inability or inadequate blood return towards the heart. That is the reason here in obstructive shock, we're going to see ultimately the cardiac output will be decreased in either way, and ultimately the tissue perfusion will be disrupted and the person will be developed with shock. So as we have studied the major classification of the shock, now you have to remember two basic things regarding shock, that either there will be a direct cardiac problem associated with the development of shock, where we are going to see the blood volume will be managed but heart will fail to pump adequate blood. In the next category, we are going to see the heart here will be unable to manage the pumping action of it. That is the reason there will be circulatory deficiency. So first we are going to see the shock which are often related to the reduced blood volume can take place for a particular individual. Now, the examples which are often related to the reduced blood volume for a particular individual includes the hypovolemic shock or cold shock, as we have studied before. Traumatic shock often can cause reduction in the blood volume as there will be injury, and that will be leading to the development of excessive hemorrhage and direct whole blood loss externally. Hemorrhagic shock also comes under this category. The next type of shock, which is almost always associated with the reduced blood volume, is surgical shock. So in surgery, as we know, the client will be losing a huge amount of blood and fluid. And if in surgery it is not managed, or adequate fluid and blood volume, if it is not managed for the client, then we're going to see the client can develop with surgical shock. The next one is burn shock. So as we know that the burn will be almost always associated with the extensive fluid loss from the periphery for the client, definitely the burn can actually lead to the development of shock, which is almost always related to the decreased blood volume. Dehydration shock is also a very common type of shock. So if a client is severely dehydrated and if their fluid volume is not managed here, we're going to see the dehydration related shock can actually occur as it is decreasing the fluid volume in the particular individual's body. Now, the next category which we are going to divide depending on the increased vascular capacity. So first we have seen the shocks which comes under the blood volume deficiencies. Here we're going to see as the vascular capacity is increased, that is the reason why adequate circulation of the blood will not be occurred in a particular individual's body, and ultimately it can lead up to the development of shock. The examples where basically the vascular capacity is increased and the circulation is not able to manage the tissue perfusion, obviously composed of the distributive shock. So as we have learned, under distributive shock, there will be coming of septic shock, neurogenic shock, and the anaphylactic shock. This all can actually cause because of an increased vascular capacity. So the difference between this two classification is basically the first classification we have seen there will be reduced blood volume. But in this classification, we are going to see there will not be presence of any blood volume deficiency, or we can say the individual will be present with adequate and normal blood volume for the body. But this is actually occurring as there will be extensive vasodilatation, and that will be ultimately leads to decreased blood supply and poor tissue perfusion. Next, we are going to learn about the stages of shock. Now, no matter which type of shock a person is going through, the stages of shock will be almost always similar for every types of shock. So let us discuss now regarding the stages of shock. So first stage of shock is non-progressive stage, which is often termed as initial or compensated reversible stage. As the term itself is suggesting, here the client will be in a stage where they are in a reversible state of physiological condition. The next stage of shock is a progressive stage. So progressive stage, also termed as a decompensated progressive stage. Here the compensation can be done, but it is a bit critical. The third stage is decompensated or a complete irreversible stage of shock. Here the client will be in a state where the management won't be proper or adequate to reverse the disease progression. That is the reason if a client is present in an irreversible stage of shock, it is very difficult to manage the client. We are going to see in initial non-progressive stage of shock, here basically the compensatory mechanism of the body will be trying to maintain the homeostasis, and they will be trying to maintain the supply of the blood basically to the vital organs. Now, as I have mentioned that basically shock is a physiological condition which is definitely occurring due to certain underlying pathophysiological process. Now, in order to manage that particular pathophysiological changes of the body's compensatory mechanism will try to adjust. And that is the reason the first stage of shock will be initiated here. We're going to see here the compensatory mechanism will definitely try to manage the circulation of the vital organs. So that is the reason even the neurohormonal activity inside an individual's body will be maintaining the blood pressure as well as circulation basically towards the brain, the heart and lung in order to maintain the major vital activity of the body. Next, we are going to see in this initial non-progressive stage of shock, the client can actually undergo extensive vasoconstriction for their vasculature. Now, that is the reason why here the person will be having peripheral vasoconstriction, but there will not be presence of any vasoconstriction for the cerebral and coronary circulation. So here as well as we're going to see the kidneys will not be receiving adequate amount of blood circulation, and definitely the kidney will be initiating the procedure through which there will be presence of water conservation will be taking place at this stage of shock for the client to manage the fluid volume or blood volume inside them. Tachycardia is almost always will be present in this stage of non-progressive stage of shock. Tachycardia basically indicating that the heart will be increasing its rate of pumping in order to manage the excessive amount of blood which is needed to maintain the tissue perfusion at this stage. So I hope you remember what is happening in this non-progressive stage of shock. Here initially, as the disease condition is causing some pathophysiological or pathological changes into the body's compensatory mechanism, that is various neurohormonal activity is initiated. Now here basically we are going to see the extensive vasoconstriction will occur throughout the body into the peripheries and to the non-vital organs. So here we are going to see only the coronary and cerebral arterial circulation or cerebral circulation will not be going under any vasoconstriction. So adequate amount of blood circulation will be managed into the cerebrum and or into the brain as well as into the coronary circulation. Whereas we are going to see there will be conservation of water through the kidney by reducing the blood supply towards it, as well as there will be presence of tachycardia, that is increased heart rate, which will be almost always associated with supplying of adequate blood. So next we're going to learn about what are the changes taking place in the second stage of shock, that is named as progressive stage. At this stage, as the client is advancing, we are going to see there will be failure of compensatory mechanism. That is the reason we are going to see there will be presence of dilatation of the arterioles, venules, even the capillary bed. So initially we have seen in non-progressive stage, the compensatory mechanism will be causing vasoconstriction basically to the non-vital organs. But as here the client is progressed to the second stage of shock, we're going to see all compensatory mechanism is going to fail, and that is the reason there will be extensive vasodilation of the capillary bed, arterioles, even to the venules. Now, as there is extensive vasodilation, we're going to see there will be increased permeability of the blood vessels. That is the reason we are going to see here the fluid will be leaking out from the capillaries into the interstitium or into the tissue spaces of the particular individual. Even there will be presence of sludging of blood inside the body. So as there is pulling of the blood and fluid from the vasculature, definitely we are going to see the client will be ultimately developing a condition of hypovolemia. There is the reason the tissue perfusion or the blood circulation will not be adequate enough to maintain or to manage the demand of the body tissues. And we are going to see if it is progressed further, the client will be present with hypoxia, or the client will be developed with a condition of hypoxic state. Now, initially at this stage of progressive phase of shock, we're going to see the client will be suffering from the hypoxic state except the tissues of brain and heart. So ultimately at this last stage, we're going to see the brain and heart, or in this second stage, we are going to see the tissues of the brain and heart will be conserving their circulation as well as their oxygen demand. Now, once the client is reached to the second stage, that is the progressive stage of shock, and if the client is not managed, definitely we're going to see the client will be progressed into the third and most life-threatening stage of shock, that is known as irreversible stage. Now, as the name itself is suggesting, it is basically a decompensated stage or irreversible stage. Whatever the pathological changes will be taking place here, it is almost impossible to reverse back into a physiological state. So here the complete compensatory mechanism will lose its ability to function inside the body. We are going to see the changes which are occurring into the progressive stage will be extensive enough to cause cellular and tissue injury throughout the body. Now, the injury will be severe enough which are not revert back to the normal functional level ever. And that is the reason here the correction of the hemodynamic status is highly impossible for the client. So hypoxic and ischemic cell injury which is taking place throughout the body will be definitely causing leakage of the lysosomal enzymes here in this stage. That will be further aggravating the condition of the development of hypoxia. Now here, definitely we're going to see the myocardial infarction will occur, which will be synthesizing the nitric oxide and will be further causing the worsening of the condition of myocardial infarction. Next, we're going to see even there will be presence of intestinal ischemia. Now, the circulation of the normal flora from the gut due to the intestinal ischemia ultimately can lead to the development of bacteremia or superimposed bacteremia shock. So basically, will be almost always associated with the irreversible stage, where we are going to see all the vital organs, even the non-vital organs, will be having extensive cellular and tissue injury, which is impossible to revert back to the normal functional level. Here in this stage, even we are going to see there will be presence of acute tubular necrosis for the kidneys as well. That is the reason the output of the body also will be disturbed severely here in this stage of irreversible shock. Now, as we have learned how the process are occurring, so I hope you guys are clear that all the etiological factors is ultimately disrupting the blood circulation, which is primarily causing the hypoxia and inadequate tissue perfusion. Now, as the patient is in a pathologic state, we are going to see in the initial period, the compensatory mechanism will be trying to revert back to the normal mechanism of the body. But as the compensatory mechanism is failed to do so, we're going to see the disease condition will be progressed from a non-progressive stage of shock into a progressive stage, where the compensatory mechanism will be completely losing its ability to maintain the vasoconstriction or maintain the circulation towards the vital organs. That is the reason here the vasodilatation will be taking place, and always the vasodilatation will be causing increased permeability of the blood vessels, which will be ultimately causing pooling of the blood and fluid into the tissue spaces. Now, this function in this progressive stage of shock ultimately is causing a hypovolemia. So this hypovolemia ultimately will be further reducing the blood volume and will be causing a decreased amount of circulatory blood to maintain the tissue perfusion. Now, in this stage, the client will, if not managed, will be progressed into the third stage, that is termed as the irreversible stage, where we are going to see the tissue injuries will be so severe enough that it won't be in a state where from where it can revert back to a normal stage. We're going to see the ischemia can take place into the myocardium. Even it will be affecting the tubular cells of the kidneys. It will be affecting the intestine, as well as in a progressed state, it will be causing interruption into the cerebrovascular circulation as well. Now we are going to read about the compensatory mechanism, which has been used, or the term has been used while discussing the pathophysiological changes into the different stages of shock. So what are the compensatory mechanism usually get activated in the body while the person is in a stage of shock? The compensatory mechanism includes the adrenergic discharge. Also, the second and most common compensatory mechanism, which often will be getting activated in the stage of shock, is hyperventilation. Basically, hyperventilation helps our client initially to manage their oxygen demand for the body, which ultimately or initially this can actually save the oxygen saturation level, but in a progress state, we are going to see hyperventilation will be causing further deterioration of the health of the individual. There are certain vasoactive hormones as well, which basically consist of angiotensin, vasopressin, and epinephrine. This are also will be getting activated in order to manage the vessel's diameter and the blood circulation throughout the body, mainly to the peripheries. The reabsorption of the fluid will take place from basically to the intestinal tissues, which is also considered as a very effective compensatory mechanism initially, as the reabsorption of the fluid is maintaining or is helped to the body to maintain its fluid volume. But in our progress state, although this compensatory mechanism will be failing to maintain the physiological functions of the body. So next, one more compensatory mechanism which often will be activated in the stages of shock is resorption of the fluid from the intercellular and extracellular spaces. And the next one is the renal conservation of the fluid. As we have studied, it will be taking place at the initial stage of shock. Here, basically, initially the body will try to maintain their volume or blood volume into the circulation so that adequate tissue perfusion can take place. Even the compensatory mechanism always will try to increase the cardiac ability of or cardiac pumping ability, which ultimately can cause a reservance of the blood circulation. But remember, if the client is not managed here, excessive use of compensatory mechanism ultimately will cause failure of the vital organs to maintain their functional ability. Even here at a progressed state, the heart of the individual will be failing to pump enough. and ultimately they will be developed with myocardial infarction. In a progress state or in a severe stage of shock, there will be disruption of coronary and cerebrovascular circulation even, and ultimately the person will be leads up to a irreversible stage of shock and will be developed with a life-threatening scenario. So as we have learned regarding the pathophysiology till here, next we're going to see the general clinical manifestations associated with shock. So first and foremost, important clinical manifestations or general manifestations often which is seen among the client, no matter which type of shock they're undergoing, is hypotension. So hypotension means a blood pressure which will be often less than 100 mmHg, or systolic blood pressure which will be less than 100 mmHg. It is basically indicating that the client may have a high chance of development of shock. The next one is tachycardia. So as we have learned that initial phase, there will be presence of tachycardia as a compensatory mechanism to increase the heart rate in order to try to meet the need of the oxygen and nutrition need by the cells of the body. So the tachycardia also is a very initial and general manifestation seen among the client who are suffering from shock. The next one is a cool and clammy skin. So I hope you guys remember that we have mentioned that there will be an extensive vasoconstriction as a compensatory mechanism at the initial stage of shock. So here we are going to see the cool and clammy skin is the indicator of the vasoconstriction. So as we have said, the vasoconstriction will not occur only to the vital organs. Other organs or other parts of the body will be having the vasoconstriction there. So that is the reason here the vasoconstriction is causing, or peripheral vasoconstriction is causing, a development of cool and clammy hand for our client with shock at initial stage. Next, we're going to see there will be presence of rapid shallow respiration. So here the client will be trying to gasp more amount of oxygen. That is the reason we're going to see the client will be present with a rapid respiration. Often the client with shock will be present with drowsiness, confusion, even irritability. So you need to remember, as the person will be in a hypoxic state in shock, as well as actually their cerebrovascular circulation can be impaired and there will be lack of oxygen inside the body. That is the reason the person will be present with drowsiness, confusion and irritability, as well as the person can often show the feature of excessive fatigue in the initial phase of shock. Oliguria almost always is an indicator for diagnosing the shock because it is a very prominent manifestations which is indicating that the client is having decreased urinary output which is even less than 30 ml per hour. It's basically suggesting that the urinary or the circulation towards the kidneys is impaired, and that is the reason the urinary flow is almost always reduced in case of shock. So oliguria is also a very common general manifestations among the client with shock. Next, we are going to see the central venous pressure will be often reduced for the client. So on examination, we are going to note it down that the client will be present with a reduced central venous pressure, which is basically indicated that the client is absolutely present with any type of shock. So next we are going to learn about the clinical manifestations particularly for each stage of shock. So initial or compensatory stage of shock, it will be often, or the person in this stage will be often present with certain clinical manifestations. Now we are going to read here about the clinical manifestations which are generally seen for the initial stage of shock. The first is the client can show extensive hypo or hyperthermia. So the next one is often the patient here will be present with a pale, cool and or warm and flushed skin. So often the interfumatory system will be going under changes as there is vasoconstriction, or in a next stage we are going to see there will be a vasodilation. The person can actually present with a cool and clammy hand and feet. Sometimes even person may show a feature of warm and flushed skin at this stage of compensatory stage of shock. The next one is the renal system. Definitely the client in an initial stage will be showing a decreased output or decreased urinary output related to the renal system. So why it is occurring, as we have mentioned, that there will be decreased circulation and it will be increasing the renin and aldosterone secretion, which will be causing a sodium and water retention in the body. That is the reason we are going to see the client may show a feature of edema and they will be having decreased urinary output. The next one is manifestations related to the gastrointestinal system. The motility of the gastrointestinal system will be reduced here, or we can see the motility of the intestinal tract will be reduced here. Whereas even on auscultation, we are going to find that there will be hypoactive bowel sound. There will be increased paralytic ileus for the client in an initial stage of shock. Even the decreased circulation of the gastrointestinal tract will cause all of these features. Client can actually present with anorexia, even a problem with the digestion, as the gastrointestinal tract will be decreased with their blood circulation. Next, we are going to see associated with the respiratory system, the person can show the feature of tachypnea and hyperventilation, which is often will be indicating that the person is developed with shock and they are in a compensatory stage. The next one is the cardiovascular related or associated clinical manifestation. Basically here we are going to see the person or the individual in this stage will be present with an increased cardiac contractility. So the heart rate here will be extensively increased for the client. Pulse pressure often will be decreased or narrowed in case of a patient of shock in compensatory stage. Next, we're going to see the symptoms associated with the neurology that are almost always like restlessness, confusion, even changes in the level of consciousness often will be seen among the client in this stage of compensatory stage of shock. In the next stage or progressive stage, we are going to see the temperature often will be an extensive level of hypothermia, and some patient, if it is related to infection related shock, we are going to see the client will be showing the presence of hyperthermia or excessive hyperthermia for in this stage of progressive stage of shock. The next one is client here in this stage of progressive stage of shock often will be present with a very cool and clammy hand and feet or extremities. The next symptoms for this progressive stage is related to the hematological system. Basically here we are going to see the feature of disseminated intravascular coagulation. So it is one of the most important complications that can be associated or that can be present for a client in this stage of progressive stage of shock. Next one or next symptoms or signs associated with the hepatic system that will be showing definitely increased liver enzymes and decreased liver functions, which will be often leads to the development of indigestion or digestion related disorders. Even the person can present with the sign and symptoms of jaundice at this stage of progressive stage of shock. Urinary output here often will be decreased for a client in progressive stage. We are going to see the urine sodium will increase here, whereas the urine potassium will be having decreased level, and there can presence of the symptoms associated with the metabolic acidosis. So basically the pH of the blood will be changed here for the client, and the client will be showing the feature of metabolic acidosis. Ischemic guts is almost always found in this stage of progressive stage. Erosive ulcers also can be present. Even there can be presence of bleeding inside the gastrointestinal tract, which often cause the symptoms like presence of melena or presence of blood in the stool, even the into the vomiting. Impaired absorption often will be found here in the progressive stage. So I hope you're now clear about the clinical manifestations of progressive stage. Next, we are going to learn about the irreversible phase and associated clinical manifestation. So basically in this irreversible stage, we're going to see the clinical manifestations associated with certain conditions, which is often will be related to the organ dysfunction. Associated with respiratory system, at this stage, we are going to see the presence of acute respiratory dysfunctional syndrome. Here we are going to see there will be increased capillary permeability, and there will be presence of pulmonary extensive vasoconstriction. That is the reason why alveolar edema will be present, and person will be often present with tachypnea, even breathing difficulties. Associated with cardiovascular system, we're going to see the same here also. The increased permeability will be present. That is the reason why the coronary perfusion will or may decrease at this stage. There will be presence of decreased peripheral perfusion even. That is the reason the client will be present with a very low saturation level of blood, of oxygen, as well as they can develop with the symptoms associated with myocardial infarction, the symptoms like chest pain, as well as dyspnea, as well as extensive fatigue and paresthesia over the peripheries. Decreased cerebral perfusion is very common feature here. That is the reason even the client will be present with an altered level of consciousness. Their orientation can often will be altered at this stage of shock. Most of the client can present with unconsciousness of this stage. So temperature, definitely there will be presence of hyperthermia for most of the client. The skin here will be definitely cyanotic, or they will be having a bluish discoloration due to the extensive hypoxia. Disseminated intravascular coagulation will often show more severe symptoms associated with it at this stage or irreversible stage of shock. Metabolic changes or metabolic acidosis and alkalosis is very common at this stage. Even the person will be present with anuria. So there will be no absolute urinary output at this stage of irreversible shock. There will be presence of ischemic gut, which will be often causing an altered level of absorption of the fluid, electrolytes, even the dietary intakes. We're going to see the client will be showing the feature and symptoms associated with the respiratory failure. Even there can be presence of severe refractory hypoxemia at this stage for the client. Profound hypotension is definitely being found among the client who are present at the irreversible stage of shock. We're going to see there will be decreased in the cardiac output as well. The decreased pressure and perfusion also will be altered the cardiac system and functions for the client at this stage. The client will be having complete loss of response, or the client will be in an unresponsive and unconscious state. There will be loss of reflexes even. The pupils will not be reactive or dilated at this stage of irreversible shock. That is the reason it is considered to be one of the most life-threatening scenario for a client, where the life saving is very difficult for an individual. So now we are going to learn about the diagnostic studies. So as we have learned about the clinical manifestations, now we should learn how to diagnose the condition of shock. So initially we have to do a detailed history collection and physical examination. Remember, almost always the client with shock will be present with altered mental status or altered level of consciousness. That is the reason the person who is accompanying the patient as well as the patient's caregiver should be asked regarding all the health history. So definitely past and present medical history, past and present surgical history should be collected. Definitely the infection, or if the person is having any allergic history or episodes of allergy somewhere near, that has to be collected. Family history should be collected. Even the client has to be asked, or the caregiver of the client should be asked about their lifestyle. History collection once done, a medical professional, basically a nurse, will be performing a complete physical examination, which includes a head-to-toe examination as well as the systemic examination. Now here basically we are gonna note down all the indicating sign and symptoms which may be associated or may not be associated with the condition of shock. History collection, physical examination at initial stage will be providing the valuable data to identify whether the person have any type of shock present, or whether the person is present with the indication that the client is undergoing a shock. Even it will be helping a medical professional to understand the whether the client is having a reversible or irreversible stage of shock. Now, as we are mentioning the history collection and physical examination, definitely the valuable data from that also will be helping a physician to take the decision to for the client to send for the further investigation procedure to find out the exact causes of shock, the stages of shock, as well as the types of shock. This definitely helps a physician and a nurse to take the decision regarding the essential medical care and nursing care in order to manage the client with this condition. So we are going to see extensive blood studies will be done here. Basically, the studies of blood cells, that is RBC or red blood cells, hematocrit, even hemoglobin studies will be done initially. Now, generally, in non-hemorrhagic shock, we are not going to see any alteration into the red blood cell, hematocrit, and hemoglobin volume. But in case of hemorrhagic shock, we're going to see that the client will be present with a decreased red blood cells volume, even hematocrit and hemoglobin volume. The next is white blood cells. White blood cells count will be often elevated if a client is having a septic shock. Otherwise, all other shock type will not be showing any feature or any changes related to white blood cell count. So often we're going to see there will be elevation of the creatinine kinase, the troponin, even the creatinine for the client, as there is a significant changes into the cardiovascular function. That is the reason we are going to see the cardiac enzymes will be elevated in this stage, because almost all people with shock will be present with a mild to moderate or severe myocardial infarction. Early stages of shock often will be showing a elevated glucose level for the client. In a progress state, often we will be able to see the client will be in a hypoglycemic state, or blood glucose level here will be decreased. Sodium potassium will show a significant change here. So definitely we are going to see the sodium and potassium initially will be having an elevation, and then in a progress stage of shock it will be having a decreased amount into the blood circulation. Arterial blood gas studies plays here a very important role. It will be indicating whether the person is present with a respiratory alkalosis or a metabolic acidosis associated with shock. Liver enzyme studies or liver function tests should definitely be done, because it will be helping to identify whether the hepatic system is also involved in the process of shock or not. Lactate level will be measured here. So often the person with shock will be having an increased lactate level in their body. Associated with this all laboratory test, we are going to do certain diagnostic procedure to find out the exact changes that is taking place into the cardiovascular system. Here, ECG monitoring primarily helps the medical professional to understand whether the client is having any alteration into the cardiac function or not. Chest X-ray often will be done to identify whether there is presence of any cardiomyopathy or any alteration into the heart structure or any other structural organ of the body that has to be noted down. Often, the pulse oximetry will be done to identify the saturation level of oxygen in the blood, which is basically a very good indicator to manage the client at an initial stage of hypoxia. Also, we are going to see here the monitoring would be done for the arterial and venous pressure. So as this general studies or the diagnostic studies will be helping medical professionals to identify the exact causes or etiological factors and the stages of the shock, definitely after that, the management would be done for the client. So whatever laboratory studies and diagnostic procedures I have mentioned, along with that, few more diagnostic studies may be used to manage or to diagnose or to conclude the case of the client as per the need of them. So as the diagnostic studies is helping to conclude the condition of shock, next we are going to see about the management of shock. So the general principle of management for the shock is generally it is said that patient with shock should be treated in intensive care unit as they need a very advanced life support and advanced technique for the management. Continuous electrocardiographical monitoring and hemodynamic monitoring should be done for the client here to manage with shock. Pulse oximeter monitoring should be done in order to understand the state of hypoxemia for the client. A reduction of the elevated serum lactate level is considered to be a very good indicator of the stressful resuscitation and is often have a very therapeutic value. That is the reason measuring the lactate level here for the client with shock is very necessary part. So as we have discussed regarding the general principle of management, now here you need to make it clear that once a person is present with certain signs and symptoms which is indicating the developmental shock, the initial assessment should be very prompt. Because remember, the shock is considered to be an emergent, life-threatening condition for the client. That is the reason the emergency management or initial management, if it is done at earliest, the client will be managed or client will be prevented for the further development or progression of this disease condition. So we are going to see the initial assessment would be including the assessment of ABC approach, that is airway, breathing and circulation assessment. We're going to see the client as soon as they're reaching to the emergency department with the presence of signs and symptoms. Definitely the nurse should assess them for their airway, breathing and circulation. So often we are going to see here the client if they're present with a problem or obstructions related to the airway, and if the GCS or Glasgow Coma Scale studies showing a number or less than 8 or score less than 8, we're going to see the person or the client definitely need a intubation. So a emergency intubation should be done or should be ensured by the medical professionals to manage the client's airway. So next we're going to see the breathing. So definitely the breathing should be assessed. So if the client is gasping or if they're not able to manage their spontaneous breathing, we are going to see the client will be managed primarily with administration of oxygen via nasal cannula or oxygen mask. If needed or if it is indicated, we are going to see the client will be provided with a ventilator support in emergent management. Circulation often will be assessed here. So basically we are going to see or we are going to manage if there is any circulation abnormality with administration of intravenous fluids, as well as there should be putting of a continuous monitoring of the vital signs for the client who are present with a shock. So if the person is having a traumatic injury, a ABCD approach should be done for the initial assessment. Now, ABCD approach includes the airway, breathing and circulation, as well as the assessment of the deficit or disability for the client. So here the assessment will be done for the client for absolute or obvious neurological deficit. We are going to see basically Glasgow Coma Scale rating or assessment would be done for the client, as well as extensive neurological studies should be done by medical professionals for the client to identify the disease progression. So the next initial management of the client is once the airway, breathing and circulation is managed, the next one is stabilizing of the cervical spine if there is any injury or fracture associated with it. The next includes the administration of high flow oxygen and providing a ventilator support if as it is indicated and as it is prescribed by a doctor. The next step of the management of a client with shock is creating an intravenous access along with 2 large bore catheter to infuse the emergent or emergency medications, as well as to induce IV fluids as needed. Either there can be need of blood transfusion, that is the reason the intravenous access should be made. The next part is blood test. So extensive laboratory studies definitely helps a medical professional to understand the pathophysiological process that is going on inside the individual's body. The next management, if there is any external bleeding, definitely that bleeding has to be managed permanently to manage or to prevent the development of hemorrhagic shock. So next we're going to see the assessment of the life-threatening scenario again will be done, and continuous monitoring of the vital signs and hemodynamic status should be done or should be ensured by a nurse and medical professionals for the client who is present with a shock. So vasopressor therapy often will be administered if the person is having a continuous hypotension even after done or even after providing the initial management. Even here, the client will be administered a indwelling catheter to maintain their urinary output adequately. Administration of antibiotic will be done if it is indicated and prescribed by a physician. So these are the initial management which will be done promptly for a client who is present with the signs and symptoms to manage at earliest. Now next, there are certain continuous monitoring should be provided for the client. This includes monitoring of the vital signs, pulse oximeter or the partial pressure of oxygen or oxygen saturation monitoring. The next one is monitoring of or assessment of capillary refill time for the client. Skin color and temperature should be monitored at a regular interval and continuously. Heart rate, rhythm and hemodynamic status should be monitored continuously. Urine output should be assessed at a regular interval. Level of consciousness would be definitely assessed for the client who is present with the symptoms of shock. Basically, the Glasgow-Coma scale assessment would be performed for the client. Next, we are going to monitor the hemodynamic state of the client continuously in order to find out any alteration in the physiological state at earliest and manage the client. So remember, the initial management and the continuous monitoring will be ensuring the prevention of the disease progression and prevention of the development of any complication associated with shock. Now, collaborative care, as we have mentioned, that it definitely includes oxygen and ventilation support with the client or for the client with shock. The next one is fluid resuscitation. It is a very important step of the collaborative care. And the next one is a drug therapy. Basically, a client with shock needs extensive pharmaceutical or drug therapy. Often, we are going to see that the client will be not going for any surgical management until and unless there is a indication like any hemorrhagic shock or any injury or any bleeding site that is causing the development of shock. So we are going to see here the fluid resuscitation will be done with different solutions of fluid. So first we're going to see the usage of crystalloid fluid over here. So basically isotonic crystalloid solution will be used for fluid resuscitation. It will be used at the initial stage of replacement for all the type of shock. So it is a very good and effective fluid which will be helping in the replacement of fluid volume at the initial stage of shock for each and every client. The next one is hypertonic solution or hypertonic crystalloid solution, often which will be used for the expansion of the hypovolemic shock. Blood and blood product often will be infused for the client. Basically, blood and blood products can be used for all the client with shock. The next, colloids will be used. Now, colloids will be only used for the shock which are except the cardiogenic and neurogenic shock. Colloid fluid will be used for all the patients. The drugs which are often used to manage the client with shock includes the presence of dobutamine. The dopamine also will be used to manage the client at earliest. The drug therapy also includes the epinephrine, the usage of hydrocortisone if there is presence of any anaphylactic shock. Nitroglycerin, sodium nitroprusside and vasopressin will be often used to manage the client with shock. So as we have studied about the collaborative care and initial management, now we should focus on the nursing assessment and management. So initial assessment would be done by following ABC approach. Vital signs should be monitored here. The level of consciousness should be assessed by scoring the Glasgow-Coma scale. Peripheral pulses will be assessed by a nurse initially. Capillary refill time, the skin changes and the coloration and temperature. The urine output also will be measured by a nurse. Intake output chart should be maintained by a nurse in order to manage the client with shock. So the goal of the nursing management here is maintaining adequate tissue perfusion. The second one is a restoration of the normal functional ability of all the organs which has been included into the pathophysiological process. Recovery of the organ function should be ensured through a nursing assessment and essential medical care. Also, it is a nursing goal that prevention of the healthcare acquired or healthcare associated complication and disease progression should be ensured. We're going to see here the client definitely has to be under a continuous observation. So nurses would be definitely performing a continuous monitoring and observation for the client. Even they will be assessing the laboratory or assessing the laboratory studies and their results in order to ensure that the client is not having any progression of the disease condition or development of any complication. Now, as the shock, we have studied that it is a preventive condition. So basically, it is a nurse's role to prevent the shock. Or if the nurse is able to assess the high risk group, it is a nurse's role to prevent the development of shock for the particular client. We are going to see once the client is present with any dysfunctions or disorder, it is a nurse's role to assess them and to identify the high risk group. Basically, the person with who are in an immunocompromised state and who are with a chronic illness, that has to be noted, and the high risk group has to be identified by the nurse in a hospital setup. History collection here plays a very important role, which definitely should include about the allergic history, about the traumatic injury, and so on, which will be helping the nurse to identify the high risk group for the development of shock. Planning should be essential. So once the nurse is identifying the high risk group, a planning should be done to provide the management in order to manage the condition or prevent the presence or development of shock. Monitoring or continuous monitoring and observation plays a very important role here, which will be ensured by a nurse. Prevention of infection definitely should be done as a health promotive and preventive action. So as acute interventions, a nurse will be managing a client with already diagnosed shock with a continuous monitoring of their physical and emotional status. Identifying the trends to detect the changes of the patient condition should be ensured by a nurse to find out any development of complication at early stages. Nursing interventions and therapies will be planned depending on the client's need, and it will be implemented in a hospital setup to ensure the comfort of the client as well as to promote the early recovery. Evaluation of the patient therapy and the effectivity of the medical care should be done by a nurse. Here, nurses plays a very important role as a communicator because they will be communicating with the caregiver as well as with the physician and other medical team regarding the need of the client. They will also play a role as a counselor, and they will be providing the emotional support to the patient, to the caregiver, as well as depending on their need, which will be definitely helping a client to recover early from the life-threatening scenario of shock. So here the nurses would be performing a collaborative management along with the association of other team health or health team member. So this is basically ensuring of getting a proper treatment procedure at the initial stage of the shock, which will be definitely helps to manage the client in a very effective way. Now, also the monitoring would be done for the neurological status, the cardiovascular status. Monitoring and hemodynamic monitoring would be done here. Vital signs monitoring also will be continuously done by a nurse in a clinical setup for the client with shock. Renal status would be assessed as well as respiratory status. Basically, the partial pressure of oxygen and carbon dioxide will be assessed here. The arterial blood gas analysis would be done by a regular interval as prescribed by a physician by the nurse. Skin changes should be noted down here if the presence of any pallor or any skin changes. Basically, here nurses also plays a very important role to prevent the ulcer formation or pressure ulcer formation if the client is in unconscious state. Definitely here the nurses would be ensuring a comfortable stay inside the hospital setup. So they will be providing a comfortable positions to the client as well as with a comfortable, calm and quiet environment. They will be providing adequate, or they will be help the client to maintain adequate personal hygiene. They will be definitely providing oral care and personal care in order to prevent the infection. Nurses also plays here a very important role to maintain the aseptic technique in the environment to prevent the infection. Next, we are going to see the home care. Definitely, a client who is suffered from a shock definitely will be having increased need, because in this stage of or the process of shock is very severely progressed condition which can affect the health and the functional ability of the individual. So here nurses plays a very important role. So definitely if a client is survived with shock and with managed with the medical care, a nurse plays a very important role to teach regarding the disease condition. The next is they definitely will be teaching the or educating the client and caregiver regarding the suggested prescribed medications, essentiality to continue the medications therapy, adherence to the medication therapy, as well as follow up should be ensured by a nurse. Also, the nurse plays here a very important role to explain the danger sign and symptoms, and also the nurse would be definitely suggesting the client to seek medical care once this sign and symptoms has been developed. Nurses will be also teaching the client regarding their exercise pattern. The resting pattern should be definitely the client who has suffered from shock should have adequate rest and sleep. So nurses would be teaching regarding the essentiality of it. A proper pacing of the rest and activity and exercise should be done by a nurse, as well as the nutritional support would be provided. Even the dietary intake, the essentiality of it should be educated by a nurse to the client and caregiver. The personal hygiene maintenance on the education regarding it should be done by a nurse towards the caregiver and patient. So I hope in this whole session you have learned regarding the shock. We have seen the definition, the types of it, the probable pathophysiological process, as well as the causes of it. We have also seen and learned regarding the probable and the most common clinical manifestations. We have learned regarding the extensive collaborative care, the initial management, the medical management, as well as the nursing management for the client with shock. So I hope you understood the session and you have enjoyed it. We'll meet you guys in the next session. Thank you.